Hello, everyone, and welcome to today's PAL. My name is Anush Mohammed, a fourth-year medical student, and today the session I will be giving is the Forensic Medicine Post-Med Crash Course. Now, before we begin, I would like to say I've tried my best to include all high-yield topics and also the questions related to those. So let's begin. So first and foremost, let's start with the electrocution lecture. So what exactly is electrocution? So we know electricity, right? So it's basically passage of electric current through the tissues. Now these tissues can be anything. This can be superficially the skin, it could be the muscle tissues, or it could be organs. So it can cause organ damage, it can cause skin lesions, and it can also cause death. So electrical injury is what we call electrocution. Now, this could be a very small current, that would mean it's trivial, or it could be a very large amount that could be fatal. So the severity ranges on different factors. So it can go from minor burns to cardiac death, right? So basically, most of the deaths that occur due to electrocution are because of cardiac arrhythmias or dysrhythmias. So we know that our heart has a pacemaker and it's related to current, etc., etc. So when this rhythm gets disrupted by outside electrical current, it can cause VFib. And VFib can be deadly within seconds to minutes. Okay, so how does electrical injury occur? So basically, it is due to electrical disruption. It can be thermal injury. It causes muscle spasms and it causes cardiac arrhythmias, like I mentioned. So, most important to remember is when the current passes through the heart, it causes arrhythmias. If it's through the thorax, what's in the thoracic cavity? The lungs, obviously. So, it can cause respiratory arrest. If the current is going to the head directly, which is very rare, but in that case, it goes from top down, and in that case, it will be affecting the brainstem. Now, there are different types of currents that exist. So we have alternating current. Alternating means changing, right? So it basically reverses the direction regularly, like over and over and over. So this is more dangerous and it's more lethal, okay? But whereas direct current is just one direct straight path. So it's less dangerous, and this can be seen in a lightning strike. So we've all seen in movies that somebody gets hit with lightning and somehow they still make it out alive. This is the reason. It's because it's a direct current. Now, again, it depends on multiple other factors, such as how long the current was passing through the body, or how much current was affected the person in the first place. So as we can see, alternating more dangerous. Why? Because it causes a sudden spasm. Okay, all your muscles undergo a sudden spasm, and if this is to affect your lungs as well, it can cause a respiratory arrest directly. Now, another thing is the hold on effect. We'll talk about this in a little bit, but hold on basically is quite literally, you can kind of tell from the word itself. Holding on to something, right? So when electricity touches a person, they can't let go of the current or the wire or whatever. So, and then we have, again, VFib, which we talked about. Now, what's the dose of current that is fatal? So 50 to 80 milliamps is fatal. Now, there's voltage, there's watts, there's amperes. I don't think this is a physics class. I don't think that's very important to know. But just keep a ballpark, 50 to 80, 50 to 60, that's fatal. Direct is less dangerous. It only causes a single muscle contraction. So it's not all of your body going through tetany, which is a spasm. The hold on effect is not present, or if it is present, it's very minimal. So you can let go of it much more easily. And then another thing to remember is alternating current is 4 to 6 times more lethal than direct current because it has a very likelihood of causing ventricular fibrillation. Okay, now let's talk about the hold on effect. What exactly is it? So basically, there's a technic muscle spasm that prevents the victim from releasing the wire, the live wire, which means it's carrying the current, right? So, for example, a person is holding a rod and it has a current passing through it. Basically, their hand will start contracting. And we know when contraction happens, or when the person closes their hand, they can't let go. And that is exactly what the hold on effect basically means. So the alternating current oscillates continuously. Oscillate means like it goes up and down, which basically means alternating, right? And that's what causes the continuous muscle contraction. It's dangerous. Why? Because it basically lengthens the time that you're holding that the person is holding the wire for. It increases the tissue injury because longer time means longer effect on the tissue. And then it also increases the risk of fatal arrhythmia. Now, AC, as I said, it's more likely to cause arrhythmia. This is just a repetition. And then 100 milliamperes for 1/5 of a second can cause VFib. So you can tell how dangerous AC current is actually. Okay, now moving on to the types and severity. So there's different types. So there's low voltage, which is less than 1,000 volts. This is what's mostly in the houses, like in the plugs and stuff like that. High voltage is more than 1,000, and it can cause severe burns. This is most construction sites have it and stuff. You don't really need to worry about this too much. Now, what does high voltage exactly do? It causes deep tissue destruction. It causes spark burns, kind of like this. Well, this is a bit more exaggerated because it's an animation, but you can understand that it starts sparking and that can cause burns on your skin. And then it forms crocodile skin, which basically looks exactly like a crocodile. But I'll even show you a picture a little bit later. Now, what basically distinguishes how severe the injury is going to be? So there's multiple factors. So one of them is skin resistance. Skin is our barrier to the earth, okay? So it's the main barrier to electric current as well. The resistance depends on how thick your skin is, more than the tissues underneath, okay? So how thick the keratinized epidermis is. If the skin is wet, there's less resistance, so it's more likely to suffer greater injury. And if it's dry skin, the opposite. And again, longer contact means it's more severe injury. Sorry, give me 1 second. I just want to put this so it's not disturbing my slides. And then low voltage current may still be fatal if it's for longer time, longer contact. The other factors that affect the injury are the physical condition of the victim. If they are thin, for example, they have less skin, for example, then they're more likely to suffer injury. The awareness of the victim, so people who are under certain drugs or under certain influences, they don't exactly know what's happening to them. So in that dissociative state, they cannot react to the stimulus, which basically affects the severity of injury. And then presence of any other disease. If, for example, if there's like a pre-existing cardiac condition, then it's more likely to cause VFib, isn't it? So that basically determines the severity. Now, another thing I would like you to pay attention to is this table over here. It may seem simple or like silly, but there's a bunch of questions about this in our exam. So the level of perception is when it's 1 to 5 milliamperes. So you can feel it when it's 1 to 5. It starts hurting when it gets up to 10. The muscle starts contracting when it's 100, and it's fatal when it's 100 to 300. So this is very, very important. Okay. Now, what causes death in this scenario? So what's the mechanism? So the most common cause is VFib, like I mentioned before. And basically the current passes through the myocardium, through the superficial epicardial layers, and this is what causes VFib, um, and that causes death. Another reason could be respiratory arrest, like I mentioned previously, but this is again less common. This is when it passes through the thorax. It causes, so we all know how we breathe, right? And what assists us in this breathing is the diaphragm and the intercostal muscles. If your diaphragm is paralyzed, you won't be able to breathe, right? This is exactly that concept. So when the current passes through the thorax, it causes spasm of the intercostal muscles. So they won't help in breathing, and the diaphragm won't go up and down to help assist the lungs to reach their capacity, right? So that causes respiratory arrest because the movement is inhibited, and that causes hypoxia, which then leads to death. Now, again, brainstem, as I mentioned, it's rare because it's mostly when the current enters through the head directly, which is not likely in many cases. In many cases, for example, if there's water on the floor, on the road, and there's an electric wire on the floor as well, if anyone was to step into it, it would go from their feet upwards, right? So from the head down is very unlikely. However, it can cause respiratory paralysis, cardiac arrest, because it directly affects the brainstem. And we all know the brainstem is responsible for everything. So if that in itself is injured, then it causes death. Okay. Now coming to the autopsy findings. So first, let's start with jewel burn, which is basically like an electric mark. As you can see here, it's small. It's pale, it's white as you can see, and it's like a crate. It's depressed inside and it doesn't hurt. This basically means this person probably tried to hold the wire, and that's where the current entered from. So this is a jewel burn. Now, like we said, crocodile skin. So this is the crocodile skin effect. You can kind of see it looks exactly like a crocodile. There's multiple spark lesions. And yeah, that's it. Now, coming to the internal findings, most of the time the internal finding is very limited or it doesn't exist. It's because the tissues in our body, they contain water and they contain electrolytes. So the current, instead of directly going through, it diffuses throughout the tissues. And if there was a smaller surface area, it would cause more injury, right? And because this is a larger area throughout all the tissues, it diffuses, and this prevents major thermal injury. Now, external burns, if they're small, it can still cause severe internal injury. In the case of internal injuries, the body may still remain pale and congested. Now let's talk about histology, the subject I've probably hated all 4 years of med school. Now, over here you can see some bubbles and you're like, what the hell is going on? Basically, this is bubbly coagulation necrosis. There's vacuolation, like vacuoles are forming, and the epidermis is getting separated. So this is what happens to the skin when current passes through it. And in electron microscopy, you'll be able to detect metallic deposits. Okay. Now, what is the manner? Now, before in our pre-med crash course, we talked about the manner, the cause, and everything, so I'm not going to get into a lot of details for it, but let's go very briefly. So manner, it can be accidental, which is most common. For example, again, like I mentioned, someone is walking on the road, there's a bunch of water there, and there's a wire that's touching that water. If the person was to walk into it, that would be accidental electrocution. Then there's suicidal, which could be like in the bathtub, they turn on any device or something that could cause suicidal electrocution. Homicidal is when someone is trying to kill someone else via electricity. Judicial means basically in the setting of court and government, and you know how in the movies we see that there's a person on the chair, he's committed a horrible crime, and then he's going to get punished, right? That is via the judicial method, which is through the electric chair, which passes 1,700 volts of electricity, and this directly causes failure of the heart and the CNS. And evacuation around the vessels can be present. And then there's the lightning strike, which we will talk about. Now, as I said, the lightning strike is direct current, but it's extremely high voltage. So it's 100K volts, and the temperature, it's really, really hot. So it's 15K to 50K Fahrenheit. This can rapidly kill unless the person's lucky and he manages to survive. Okay. Now let's talk about more lightning, right? So what do you find in a lightning strike victim? So there could be cardiac arrest, respiratory arrest, burns, fractures, ruptured tympanic membrane. Now, why exactly burns? Because the first two we've low-key covered already before, where I've explained it. It's the same mechanism. Why burns? Because I mentioned that the temperature is very, very high, and that can cause a burn. Fracture, because it's coming with a lot of force, so it can break a bone as well and cause fractures. And then ruptured tympanic membrane. So the exit is usually through the feet. Now, when a lightning strike hits a victim, it strikes their head or their body most of the times, right? So if it strikes their head, it is likely to cause CNS arrest, like we mentioned. And then it goes all the way down to the feet, and that's where it exits from. Now, when it's coming from with all this force and exiting down through the feet, it can cause torn shoes, melted shoes, or it could completely blow off the shoe, and you'll find the shoe somewhere else, okay? Miles away. Another finding that you can find is singed hair. Basically, if anyone knows how laser works, right? So it's really hot and it kind of singes the hair, it burns the hair, and that's the same concept that a lightning strike has. And then there can also be burns beneath the metallic jewelry. Now here we can see there's a zipper, and the lightning got attracted to the zipper, and that's where its point of entry was, okay? So another very important thing is metal and lightning do not interact. So please, if you're going anywhere, make sure that you're, clear of all of these things. Okay, now what do you find after a person has been struck by lightning? So how can you tell that this was due to lightning? Now you see these marks, these marks, these marks. So there's different types of skin features that a person can develop. It can be linear burns, punctuate burns, or feathering. Now, the most important to remember is Lichtenberg figures, okay? It's kind of like a fern. Fern, like the plant, you know what I mean? So it's like branching, and it's fern-like, and it causes a discoloration. This is pathognomonic for lightning, okay? It's very, very important to remember. This is not a true burn, it's just it's like a tattoo that forms because of lightning. It's a vascular phenomenon. It does not last for very long, so it's short-lived, and after a day, 24 hours, it goes away. Now, why exactly does this vascular phenomenon occur? It's because underneath what's happening is that there is RBC hemolysis, there's necrosis and lividity, and it's very important to know, again, that Lichtenberg figures directly mean it was a lightning strike, okay? Now, these may also persist after death. Why? So, because, like we mentioned in the first crash course, it's post-death, there's no inflammatory response. If an inflammatory response still existed, this would be cleared away in 24 hours. But after death, that's not possible. So you will find these marks on the victim even after. Okay. Now I'm not going to go through the key point slide because it's exactly the same thing I mentioned. It's just for you to help you out if you're like in a rush. Okay, now let's do questions. So, what is the major barrier to any electric current, and how does this affect the body's response to electrocution? Okay, so is it blood? No. Blood is internal. Is it muscle? No. Is it bone? No. I don't see how that would even be relevant. Is it skin? Yes, because we said skin is keratinized, and keratinicity, if that's a word, the thickness basically determines the severity of the burns. Second question. What are the most common causes of death in cases of fatal electrocution, and how can they be prevented? Now, is it organ failure? No, because organ failure is mostly like a chronic process. It didn't take place seconds after, right? Is it blood loss? No, because unless there's a like a penetrating wound or like an injury or a loss of dermis, only then it causes blood loss, you know? Blood has to go out from somewhere. Is it brain damage? No, because as we mentioned, it's least likely to be brain damage because most of the time, the victim gets the current from either like the body or the feet and not the brain. So the answer here would be heart failure because it's very prone to arrhythmias because of current. How many milliamps of electric current would cause pain? 5, 10, 100, 5,000. So the answer here is 10 milliamperes. So this is exactly why you need to know this table by heart, okay? So make sure you go over it a bunch of times. Okay, that's for the first lecture. Now, the second lecture, crime scene, is super, super basic, okay? We've covered this mostly already, pre-mid, so I'll quickly rush through this because I don't want to waste a lot of your time. Okay, so what's a crime scene? Crime scene is where the offense occurred or where the crime occurred. It could be the actual scene, and it also contains the planning area, like wherever the criminal plans and comes up with his strategy. And then the path he takes from point A to the final path. So the pathways in between are also part of the crime scene. So where you find the body is not always the primary scene, okay? And the importance of crime scene basically helps us understand why the death happened, what manner was it, and what events took place before the death took place, if that makes sense. The biggest mistake a forensic physician can ever make is not going to the death scene. Sometimes you send your juniors or whoever and you tell them to go do the work. Go see, go investigate. But that's the biggest mistake. If you do choose to be a forensic physician, you need to make sure that you go to every single site and investigate yourself, okay? Okay, now coming to the types of crime scene. So there's a primary scene. This is where most of the assault or the crime took place. It's where most of the evidence is also present, which could include the body. The secondary scene is where some interaction took place, where the criminal was planning, he had a whole board like we see in the movies, with his whole strategy planned out. That's the secondary scene. And the intermediate scene is between the primary and the disposal site. So if a vehicle is transporting a body, the vehicle is considered a intermediate scene, okay? Now, if the victim is moved after death, you need to be able to investigate if the crime took place at that spot or if this took place somewhere else and the victim is now here, okay? This can happen if, for example, if there's a hanging marks on the victim, and what's weird is the fact that you found this victim on the road. So you would think he would be ran over or something, but that's not the case. If there's hanging marks, that means the crime did not take place here. The victim was hung and then moved to the road. So in this case, the road is the secondary scene. The original room where the assault took place is the primary. and the vehicle or the transport that took place in between is the intermediate. Now, there's different classifications. I won't get into it. You can read it through. It's very simple. One thing I would like to say is that every contact leaves a trace, even if it's the most minimal interaction that you've ever made leaves a trace. If you go meet a friend, you have lunch or you do whatever, you might leave a piece of your hair there. You know, like there's every contact leaves a trace. Every place that a person visits leaves a trace. Okay? So that's why it's very important as a forensic physician to analyze the scene very, very carefully. Now we'll talk about how the analysis should take place. It could be sketched out, the scene could be sketched out, or pictures can be taken, and it's very important to make sure the scene analysis is done properly. And then, because that helps us reconstruct the scene to identify what exactly took place. Now, rules at crime scene: safety first, protect the scene. Don't let other people just randomly walk into the scene. If there's a car accident on the road, the first thing the police does is secures the site until the forensic physicians get there. Because they can't have people walking to and from, because every contact leaves a trace, right? So you don't want it to disrupt your investigation. So you restrict entry, and then you document everything that you found in that scene. And then you do proper evidence collection. Okay. Now, how do you approach the scene? So before you touch anything, you take a look at the scene itself. You take pictures from afar, and then you go close. And then you interview the people who may have been witnesses in in the surrounding area. Before you move anything, it's important to take pictures, okay? So you examine the body, you see the position, if there's any injuries, if the blood is distributed evenly, if there is pooling, hypostasis, and so on. You see the nearby objects, if any are present, and then you try to identify the time that the death took place, okay? You identify the time that the death took place and whether the body was moved or was this the original position. So we've talked about hypostasis before, but over here I would like to mention that if it's inconsistent hypostasis, that means the body was moved, okay? And then rigor mortis, and then injuries. You examine all of these things and then you document. And how can you document? Through photos, videos, sketches, notes, and they have to be accurate, complete, and permanent. These seem like very silly, random things, but these things do come in the exam, which is why I'm, reinforcing these concepts. Okay, now scene up close. So what do you do when you go to the scene as a forensic physician? You take distant shots, then you go close up, you take multiple angles, you go and you check the entrances, the exits, the windows, every single thing. And then whatever evidence you get, as you can see here, there's a ruler. It basically helps keep things in scale. Otherwise, things can be like disproportionate, Over here, as you can see, it was taken from far. Every angle of the room you can identify. And then this is the body. And this is the cabinet. And now you can see that there's pills present here. Then you go close up and you can see what kind of pills they are. So this is why it's very important to learn how to approach the scene. Oops. Okay. So how do you search the scene itself? So there's different methods, okay? There's spiral search, there's grid, there's strip or line, there's quadrant, and there's other like wheel, x-ray, and so on. Before I show you the pictures of that, I want you to pay attention to this image here. So I said that you have to draw the scene out as well, right? So there's an initial sketch made, which is the rough sketch. It's drawn at the scene. You can see things are not up to proportion, right? It's just to give you an idea of what the place looked like. And then when you go home or when you go to your office, whatever, You sit down and you make it with a ruler, you make sure it's precise, it's to scale, and so on. Now, coming to the methods of how you do your search. So spiral, literally, we all know what a spiral is. You go from here and you go move out in a circular manner, or you can do it the opposite way, whatever you like. Then there's the grid method. The grid method is divided into rows and columns, and then each square is searched. So you go from one square to the next, to the next, to the next, and you repeat the whole thing until you've covered the whole surface area. Okay. And then we have the line search. So you go in one line, and then you take a U-turn, and then you go in one line, and you can take a U-turn, and so on. And then the quadrant or zone search, this is when the area itself is much bigger. So you divide it into 4 boxes, which you divide it further into 4 more boxes, and you search each box. One person can do this, 2 people can do this. It's just important to make sure it is done systematically, okay? You can't start from one place and the person is starting from the middle, and then you're confused what area you've covered and what you've not. Okay, now evidence collection. So how is evidence collection done? So first and foremost, we need to see if there are any witnesses or victim statements present. Okay, so that's called testimonial. So we get physical evidence, we get hair, fibers, fingerprints, biological material, which could be any like fluid, saliva, and so on. And then we see if there are additional evidence that could link the suspect to the victim, to the scene. Then again, we look at trace evidence. What does trace evidence even mean? So trace means very small, very little, right? So that could be hair, fibers, skin cells, and these are usually microscopic. The main goal of evidence collection, like our main goal, is to prevent contamination. You don't want to lose the evidence and you don't want to damage the evidence. So everything that you collect is packaged separately and then you put a label on it so you can identify it later on. Now there's a chain of custody, which basically means that it goes from the police officer to another police officer to a forensic physician to the court and so on. This is just to give you an example of the chain, okay? So whenever it's passed from person A to person B, it has to be documented. So continuous documented handling of evidence is what chain of custody is all about. If this is broken, then that evidence, no matter how important it was, means nothing in court. Okay, and then what evidence we collect from the body, which could be clothes, any clothes, any fingernail scrapings, hair, blood swabs, bullets, and so on. Now, as a forensic physician, what is your role? So your role is to confirm death, estimate the time of death, you identify the person who is deceased, and then you determine how, yani the cause and the manner of death, and then you preserve the evidence, and lastly, you make sure that you supervise the body removal. Okay, again, key points, but that's it for the crime scene lecture. Now let's go on to questions. So, first question, the location at which some of the victim-offender interaction occurred, but not the majority of it, where additional evidence may be found, is known as what? So, primary crime scene is where most of the thing occurred, right? Intermediate crime scene is like the vehicle, transporting, and so on. Or planning areas, or secondary crime scene. So what's the answer? The answer is secondary crime scene, because some of the victim offender interaction took place here. Now, hair, fibers, skin cells are what type of evidence? As I said before, this is very, very small evidence, which you can like correlate to the word trace. So this is trace evidence. And then finally, what is the importance of collecting physical evidence from the crime scene? So the answer here is the search for physical evidence should continue to the autopsy room of a deceased victim. So make sure you go over all the primary, secondary, intermediate crime scenes. Okay, now coming to complications of mechanical injury. So as we can see here, there's three. We'll talk about more, but let's start with acute respiratory distress syndrome. So what exactly is acute respiratory distress syndrome? So it stands for ARDS, okay? Okay. It's also called diffuse alveolar damage. It's called a shock lung or acute lung injury. This is what it looks like histologically. When I had to give the forensic medicine exam, the doctor said, you don't have to pay attention to this. But I was going over some of the past exams for FMT and I found this in one of the questions. So it's better to just, identify it so you can correlate. Okay, so what does ARDS actually mean? So it's basically acute hypoxemia with pulmonary infiltrates. There's increased pulmonary vascular permeability, and it causes epithelial and endothelial injury. This is very, very common in neonates. So when you do your peds rotation in next year, in whatever hospital, you will find at least one patient who has ARDS, okay? And they're most likely a neonate. Why exactly does this happen? There's multiple reasons. So it could be sepsis, it could be infection, it could be trauma, it could be gastric aspiration, contusion, fractures, burns, drowning, radiation, and so on. You get the gist, okay? Now, what do you find in art macroscopically? Now, I want you to pay more attention to the macroscopic features than micro because they're more likely to be asked, okay? So the lungs are heavy, they're firm, they're red, and they seem very edematous, okay? There's a lot of edema inside, basically. Now, the microscopic appearance is kind of described here. So there's hyaline membranes, which is a characteristic finding. There's shedding of type 1 pneumocytes, proliferation of type 2, and there's interstitial and intraalveolar edema. Excuse me. There's pulmonary fibrosis and there's thick septa, as you can see here in between them. Okay, now coming to suprarenal or adrenal hemorrhage. Now, it's basically massive adrenal hemorrhage after trauma. This could be a blunt force trauma or any kind of trauma. However, it's a rare complication, but it can be on one of the adrenals or both, okay? If there's both, it's more likely to cause adrenal crisis. Now, what are the features? So, death usually occurs from adrenal hemorrhage, a suprarenal hemorrhage, after 2 to 21 days after trauma. It's diagnosed at the autopsy because this is what it looks like. So you can clearly tell that something is wrong here. And that points to hemorrhage, right? You can see so much blood. The history is very important, and this is not due to direct adrenal injury itself. Most likely cause is trauma. So it's likely to happen in a road traffic accident, which is why it's important, even if anyone has ever been in a road traffic accident, the first thing you go do, if it's a bad accident, you go get yourself checked out, because you never know what's happening internally, right? So the person has to go get checked out. It's very important. So road traffic accidents is the most common cause. Then it could be perinatal trauma, breech birth, fetal anoxia, meningococcal septicemia, post-op septicemia, tumors, hypertension, renal failure, and so on. This is what it looks like microscopically, but I don't think you need to pay much attention to that. Okay, now coming to the autopsy findings, the pictures that are shown right here. So the adrenal gland, it looks swollen. You can see dark red hemorrhage in the medulla. And this also is present in putrefied bodies. Okay, now coming to thrombosis or embolism. So what exactly is a embolism? So thrombus is a clot that forms. If this clot forms in the deep veins of the leg, it's called a DVT, right? Now, from a main thrombus, a small part of it can break off. That small part that breaks off is called an emboli. Now, this emboli can go lodge anywhere in the body, okay? Most likely, this is going to lodge in the pulmonary system. So it can cause pulmonary thromboembolism. It's the most underdiagnosed cause of death because sometimes if this is a minor PTE, it will be completely asymptomatic. So nobody would be able to tell this even took place. This mostly happens 2 weeks after trauma. Now, why do trauma patients develop DVT or PEs? Basically, because we all know the Virchow's triad, okay? So venous stasis, endothelial injury, and hypercoagulability. And that's exactly the reason, plus immobilization, which causes the venous stasis. Now, additional causes include tissue trauma that increases coagulation. There's injury to the legs and pelvis. And injury to the legs and pelvis is the most common cause of a thrombus or embolism. There's reduced venous return during bed rest, which the victim is most likely to be resting in bed most of the times after a traumatic injury. So this mostly affects the deep leg veins, popliteal, and femoral. Femoral, it's more likely in like pregnancy and so on. Mostly you have to remember it's the calf veins, the soleus veins, which suffer a thrombus formation. Now, small emboli can go and form in the pulmonary circulation, like I said. So in the pulmonary arteries peripherally, and it can cause pulmonary infarction as well. There's also massive emboli that can occur in the major pulmonary vessels, and this would be very, very symptomatic, and the condition of the patient would deteriorate very, very rapidly. And this can also cause sudden death. Okay, now coming to examination of how a DVT is done, like how a DVT forms, and dating the DVT. Okay, so how do you look into a DVT? You basically make transverse or longitudinal cuts in the calf. You examine the soleus muscle, the gastrocnemius, and the veins inside. So these are the calf veins that you can see have a thrombus in them. Sorry. And then there is some clues that tell you when exactly it took place. So if polymorphs are present, it's the first day. If there's endothelial budding, it's the second. If there's fibroblast formation, it's end of the first week. If there's hemosiderin deposition, it's end of the first week as well. And if there's elastic fibers, it's after 28 days. Now, the most useful area to kind of estimate when this took place is the thromboendothelial junction. Now, what's the difference between an antemortem versus a postmortem clot? So an antemortem clot is firm, it has a dull surface, it's laminated, it's gray-red in color, and it has these specific lines called lines of Zahn present on them, and they can completely unravel. However, a postmortem is soft, jelly-like, it's glistening, as you can see here, like it's shiny, it's smooth, it's dark red in color, there's no lines present, and it forms a cast of the vessel itself. This is also called a chicken fat appearance. Okay, now let's talk about saddle and paradoxical embolism. So what's a saddle embolism? It's when there's a large embolus that gets stuck at the bifurcation of the pulmonary artery. So right here, this is a saddle embolus, okay? You don't need to go into a lot of details for this, just remember this picture and what a saddle embolism is. Now, what's exactly a paradoxical embolus? So a paradoxical embolus is when the embolus passes from the right heart to the left heart. And I don't mean through the normal circulation. I mean that there is a hole in the heart and it's passing through it directly, okay? And this could be through a atrial septal defect or a ventral septal defect. So that's what a paradoxical embolus is. Then we have ear embolism. Now, ear embolism can be arterial or they can be venous, okay? Now, let's talk about what they are. So they're basically gas bubbles that obstruct the circulation. Now over here, you can see this is a vein, and this is a venous air embolism. Why does this happen? It can be due to trauma, surgery. It could be any therapeutic procedure the patient did. It could be barotrauma or homicide. So air basically travels to the right heart, the pulmonary arteries, and the fatal volume usually is 100 milliliters per air. Now let's talk about arterial air embolism and fat embolism. So arterial air, as you can kind of see over here, you can see the bubbles, and this is the artery. This can happen due to carotid laceration, lung laceration, and barotrauma. Now, the death here takes place due to cerebral airlock or coronary embolism that can cause VFib. However, peripheral artery air injection is usually harmless. Okay, now moving on to fat and bone marrow embolism. So, fat embolisms take place most of the time due to long bone fractures or pelvic fractures, or it can be crushed fatty tissue. What happens is that the fat enters the bloodstream into the blood vessels, and it enters at the time of trauma. The symptoms, however, can appear later, and this is called the lucid interval, which means during this time, the person is completely fine, and then after, suddenly symptoms start developing. This is because of fat hydrolysis and endothelial injury, and it can mimic subdural hemorrhage. Now, this is the classification of a pulmonary fat embolism. So, grade 0 that means no emboli at all, obviously. 1 means it's seen after you do some digging, you search it. 2 is it's easily seen. 3 is that there's a large number, and 4 means potentially fatal. Now, I forgot to mention that what exactly does barotrauma mean? So barotrauma is tissue injury that's basically caused because of a difference in pressure between the inside of the body and the outside environment. It most commonly affects air-filled spaces like the lungs, the GI tract, and so on. The most important thing is pulmonary barotrauma, and this happens when the alveoli overexpand and then they rupture because of the changes in pressure. And again, this can lead to pneumothorax and a whole sequelae of things. This was just to clear it out. You don't really have to memorize it for the exam. Okay. Now, I've mentioned this already. Now let's talk about systemic fat embolism. So the most common sites are the brain, heart, and the kidneys. And the brainstem can be involved, and it's most likely to cause death. On the autopsy, you find a fat embolism. Now, there can also be petechial hemorrhages on the chest, face, and eyelids. And how do these show up? These show up in the brain as white matter petechiae. In the heart, it shows up as fat in the interfiber capillaries, and in the kidney as fat in the glomeruli. This is fat embolism. Now coming to crushing syndrome. So what exactly is crushing syndrome? Is basically a complication of severe muscle injury that can happen after a road traffic accident, for example, or extensive burns. It can be caused by other things such as mercuric salts and carbon tetrachloride. So what basically happens is that the crushed muscles, they trap a large amount of fluid, and this causes the intravascular volume to decrease. Then there's renal vasoconstriction, renal ischemia, and the most fatal complication is acute renal failure. So what exactly do you find in crushing syndromes in terms of renal findings? You find myoglobinuria, which is myoglobin, it starts getting released from the damaged muscle, and it can cause tubular casts. So brown tubular casts, tubular obstruction, epithelial destruction, and distal tubular necrosis. Okay, that's it for the mechanical injuries lecture. Now let's do some questions. So the Mason scale is used to assess the histological severity of fat embolism. Which of the following explains what grade 2 represents on the scale? A was supposed to be here, but let's ignore that. So A, no emboli seen. B, found after some searching. C, present in large number. D, potentially fatal number, or E, easily seen. So, grade 2 means easily seen. Now, second question. A clinician examined a man who had extensive muscular injury. His myoglobin was found to be concentrated in tubules and forming brown casts which were blocking the tubules and causing destruction of the renal tubular epithelium and distal tubular necrosis. So what's the diagnosis? It's Cushing syndrome. Again, just to reiterate, Cushing syndrome happens because of mercuric salts and carbon tetrachloride. Okay, now coming to the next lecture. So, road traffic accidents. So, road traffic accidents are the most common cause of death under 50 years of age. They're mostly common in young males because we all know how people drive, especially here in Saudi Arabia. So, the common causes of fatal road traffic accidents are mostly alcohol or drug impairment. This is mostly common in the US. It could also be human error, which could be speeding, falling asleep, being on your phone, and so on. Then we also have environmental hazards, which is bad weather, icy roads, or roads that are not built properly, so they have bumps and so on. Natural disease causing accidents is rare. So it's very rare to see that someone had a stroke and then they passed away because of an accident. Most of the times, it's because of intoxication, which is why there's a toxicology test required. Now, what are the different types of vehicle collisions? So there's frontal impact. There's rear impact when someone crashes into the back of the car. There's side impact when someone crashes into the side of the car, where the passengers usually are. And then there's rollover crash is when the impact is so much that the car flips, and that's called a rollover crash. Now, the injuries may involve the people that are in the car, the driver, the passenger, front seat, back seat. It could also injure the pedestrians, and even motorcyclists could be involved. So the injury pattern depends on where the person is sitting. Rear seat passengers, they suffer more injuries. Why? Because most of the times there's no airbags on the sides, at the back, and there's lack of restraints. Most of the time, people don't usually wear their seat belts at the back, which should not be the case. You should always wear your seat belt. Okay, now there's different levels to injuries. So level 1 is upper level injury. So what happens is basically if a person is driving and they get into an accident, the first thing that happens is that the head of the person strikes the windshield, okay? So right in front. So the energy transmitted goes from the skull directly to your C-spine. So what happens is you can avulge the forehead. There could be the person can avulge the forehead. There could be a basilar skull fracture, a closed head injury, or a C-spine fracture, like over here. Most commonly, what happens is atlanto-occipital dislocation. Now, when there's this dislocation or fracture, it completely transects the cord, and that causes paralysis from there all the way below. Okay, then we have level 2 injuries. These are middle level injuries. So this happens when the impact is against the steering wheel or the dashboard. So this includes facial injuries, neck injuries, wrist or arms, radius forearm. So the driver basically braces themselves against the steering wheel. For example, imagine there's a driver that's holding the steering wheel and there's a sudden force. What happens is that it fractures the arm of the driver. Okay, now you can see here the injuries I've already talked about. Now let's move on to more injuries. So everything can cause injury in the car, okay? So even the steering wheel itself can be impacted against the body of the driver, and this can cause jaw fractures, facial bone fractures, rib fractures, flail chest, liver lack, and spleen lock, and chest contusions. Now, flail chest is when there's multiple rib fractures, and what happens is that the ribs can puncture the lung as well. Okay. Then we have thoracic deceleration injuries. So these are severe injuries. This includes aortic laceration or transection. This is often fatal. Myocardial laceration, sternum fracture, again, flail chest, or tracheobronchial disruption. You can see here, these are multiple rib fractures that can cause flail chest. You can see this is the imprint of the steering wheel. And then we have lower level injuries, which is level 3. What happens here is that the knees hit the dashboard. So the lower limbs, right? So the force is transmitted through the pedals. And what's injured here is the tibia, fibula, so tib-fib fractures, femur fractures, pelvic fracture or dislocation. And the thing with pelvic fracture is it can cause severe internal bleeding. So over here, this is level 3 injury. Okay, now let's talk about more injuries. Okay, so rear impact injuries. Now, as I said, if someone crashes into the car from the back, that's a rear impact injury. So these are usually low velocity, which means there's not a lot of speed into this. But the thing is, this can cause whiplash injury. Now, whiplash is very, very important for you to remember. So what happens basically is one thing I would like you to pay attention to, that there's no headrest over here, okay? So what happens is that there's acceleration, deceleration, okay? So the person's head goes all the way back, which is hyperextension, and then it goes all the way front, which is hyperflexion. So this hyperextension, hyperflexion can basically cause C-spine injury or soft tissue injury, which is why it's very important for the person who's driving to make sure that the head restraint that's at the back is positioned at the level of your head to make sure you avoid any injury. Now, there can also be high velocity rear impact. Now, when the car comes with a lot of force, it can cause the gas tank to rupture because we know the gas tank in the back. Then it can also cause fuel ignition and the vehicle can catch fire. Okay. Then let's talk about side impact crash. So you can see over here, the reason side impact crash, the injuries are so severe is because think about the car, right? So at the front of the car, there's the bumper and all the things in the car. Don't ask me to name them, but there's a bunch of things, right? And at the back of the car, you have the trunk. So the seats are in the middle, technically. However, if a car is hit from the side, it's hitting directly the passengers inside the car because there's only the door on the sides, and that door is very thin. So the force absorption by the car itself is minimal. The force goes and hits the people inside, the passengers inside. I'm sorry for being so gory, but I need to use examples to explain. Okay. Now, the most common injuries in this case, again, C-spine fracture. Anytime you hear a road traffic accident, first thing comes to mind is a C-spine fracture. Then there can be rib fractures because the ribs are on your sides, and the person, if a person is in the car and there's a side impact, it's more likely to hit the ribs. Okay. The rib fracture can then cause a lung lock, and it can also cause a lung tear. Now, there's also abdominal injuries. If it's on the right side, it can cause liver laceration because we know the liver's on the right. And then if it's on the left side, it can cause a splenic injury or a splenic lock. Okay, the kidney is less likely to be injured, but it can also happen. And pelvic fractures are very common. Okay, now let's talk about more injuries. So rollover, I kind of explained already how it takes place. Usually what happens is the accident itself is very severe, and different vehicles, they absorb force differently, okay? So it depends on what kind of vehicle you're in. Now, there's two types of passengers, belted passengers and non-belted. So those who wear their seat belts and those who don't. Now, the people who wear their seat belts, they often survive because they're not thrown out of the car, okay? The passenger remains inside the compartment of the car still. Non-belted occupants, they suffer more injuries because what happens is when there's this force and something is turning upside down, the passenger inside starts tumbling. So they hit different parts of the car, and what can also happen is that they can kind of like eject out of the vehicle itself from the front view mirror, okay? Then, as I said, they suffer more injuries. Now, most common injuries in ejected occupants is head injuries, neck injuries, and abrasions. The most common thing to happen is road rash. You see, all of this skin is peeled off, and it seems like there was so much friction that kind of just like eroded the skin. This is what a road rash is. This happens to the passengers that are ejected out of the vehicle, and then they slide across the road, and that kind of pulls away their skin. Okay. Then we have airbags. So airbags, they're very, very useful. They reduce fatalities and injuries. So the airbags alone can help 14%. Seat belts alone can help 45, and together it can be 50 to 60. However, nothing in life comes with a drawback. So there are airbag injuries as well. And they can be fatal as well, because what happens is when a person gets into a car crash, the airbag deploys based on the force the car is hit with, right? When this airbag deploys, it kind of bursts open. Now, when this bursts open, it comes onto the passenger with so much force that it can cause facial bruising, eye injuries, it can cause chemical burns, C-spine injuries, head injuries, abdominal injuries because of the force alone. Okay, then we have pedestrian injuries, which are acceleration injuries. Occupant injuries are mainly deceleration injuries. So acceleration means that if there's a car on a road, if a victim is passing, like crossing the road, and the car hits the victim, that's an acceleration injury. And the severity depends on what the type of vehicle is. So a truck is different from a car, and a car is different from a bike. You get what I mean, right? And then the speed, with what force the brake was implied, or how fast the brake was implied, and the height of the victim as well. Because at the level of the car, if it's a tall person, the car could hit their legs instead of their abdomen, right? So height also matters in this scenario. Okay, now we'll talk about more injuries. So these are just pictures I've added of dicing and shredded injuries. These happen mostly because of the glass that breaks from like the windows and the windshield. Okay, now coming to run over injuries. So over here you can see that these are tire marks, okay? These can break through the clothes and the skin, and this leaves like an abrasion. And then this can also cause crushing injuries. Then we have degloving injury. Degloving is basically like taking off your gloves, right? You take off your gloves. That's what it means. I don't know if you can picture it, but let's talk about it a little more. So it's basically when the skin tissue is torn away by the force of the tire, by the tire shearing force. And this can cause severe crushing, it can cause amputation and fragmentation. So as you can see here, this is a degloving injury. Then there's motorcycle fatalities. So they resemble ejected occupants because they're not inside a compartment, right? They are on their own on the motorcycle. So what happens in these cases is they don't have a seatbelt either, right? So they are ejected out as well, and that can cause a road rash. It can cause head injury, like we mentioned, pelvic injury, and leg fractures. This is also a degloving injury, by the way, just very minor in comparison. Then we have a hinge fracture. So a hinge fracture is when there's a fracture, transverse fracture at the base of the skull over here. And it's characteristic for motorcycle people. So motorcyclist fracture. Their other fractures can be skull fractures, cool counter cool, which is just acceleration, deceleration. And then the helmets reduce the head injury risk. So it's very important to wear a helmet while someone is riding their motorcycle. And then lower limb injuries are very common, so tib-fib fractures and leg injuries. Okay. So, what's a forensic physician or your role in an investigation of a road traffic accident? So, you examine the vehicle, you correlate the injury, and you examine the clothes, you take photos, and then you do a toxicology test, to make sure that the person driving was not under an influence of any kind. And then we have the pedestrian investigation in the case of a pedestrian being hit. So you incise and you reflect the skin, you look for any bumper marks on their skin, and then you measure and you take photos. Again, key points. Okay, questions. So in a road traffic accident where there's a fracture or dislocation of tibula fibula, so tib fib, and pelvis, this injury is called what? This is called level 3 because tib fib is lower limb, right? So it's level 3. Then the second question, road traffic accident causing a fracture with complete detachment of part of the ribs. What is this condition called? So this is called flail chest. And then third question, what is the characteristic difference between a victim ejected from the vehicle and not ejected? So as I said, it's road rash because of the whole concept I described earlier. Okay, now let's start with our next lecture. So next we have ballistics. So what does ballistics mean? It means it's the science of dealing with firearms, ammunition, and projectile injuries and the effect it has. So what's a firearm? It's basically a device that propels a projectile by explosion of gases. Now, this projectile, it can be a bullet or it could be pellets as well. And that's called ammunition. So the material that's used in the firing is called ammunition. It could be a bullet, powder, primer, cartridge, and so on. So this is a firearm. In layman language, it's a gun, right? So there's different parts of a gun. So the main parts are the barrel. This is the barrel. It's a hollow steel tube, and the internal lumen is called the bore, okay? Now, it has two ends. So the muzzle is the front end, and the breech is the rear end. Then we also have a breech plate, okay? Now, coming to the chamber. So the chamber is the wider posterior part that houses the cartridge, that contains the cartridge. So this here is the chamber, which contains the cartridge, okay? Then we have the grip or stock, which is this. This is usually where the bullets and so on, you like clunk it onto it. If anyone's ever played any game, you know, like Call of Duty and something, you know what the parts of a gun are already. Okay, so this should be a refresher course. So then we have the action. So the action has different parts. So there's the trigger, which you pull and that puts the firing pin and then pushes the ammunition through. Then there's a trigger guard, which is this part. Otherwise, the trigger can be hit at any time. There's a hammer or striker that strikes the primer. And yeah, these are the parts of a gun. And then we classify firearms based on different things. So it's classified according to barrel. Now, a reminder, this is a barrel. There's a muzzle end. There's a breech end, okay? Okay, sorry about that. So there's a muzzle end, there's a breech. And if it's both the same size, it's just one go. However, if it's one size is thinner than the other, it's called choking, which we'll talk about. Okay, so the firearm is classified according to the barrel. So there's smooth bore, which means there's no rifling. It fire pellets, which are like tiny circles or balls. They're less accurate, and an example of this is a shotgun. And then there's rifled firearm, which has spiral groove, that kind of spins the bullet while it fires it, and that makes sure that it's more accurate and it has more force behind it as well. So this spiraling are the grooves. We'll also talk about this more. So it can be the smoothbore firearm, which is the shotgun, can be classified according to the length of the barrel, how you load the gun, how many barrels there are, and if it's choked or not, which we'll talk about as well. It can also be classified according to velocity. So low velocity is a revolver or a pistol, and then high velocity is a machine gun because like goes really fast with a lot of force. Okay, now as I said, we'll talk about choking. So what exactly is choking? So this is a barrel. So if the muzzle end and the breech end are different sizes, if the diameter between them is different, then that's called choking. So this is half choking. As you can see, it gets thinner as it goes to the end. And this is full choking, which you can see is much more, the diameter in between is a lot thinner. So choking is basically narrowing of the muzzle end. It keeps the pellets compact and it reduces dispersion. It increases the force through which the pellets go. That makes the gun more lethal and it gets a better range as well. So the degree of choke is the percentage of pellets inside a 30-inch circle at 40 yards. I don't know what that means. I don't think it's very important either. It's just a definition. Okay, so coming to cartridge. So what's a cartridge? So the components of a shotgun cartridge have the case itself, okay? Then it has pellets, like you can see here. So this is the whole case, okay? This is the pellets, which are small, tiny balls, basically. Then there's a wad. This could be made out of cardboard or whatever. There's gunpowder, which we'll talk about. There's different types of gunpowder. And then there's a primer, okay? And then the function of the cartridge, the function of the cartridge case is it holds all of these materials together. It prevents the gas from going backwards, and it protects the contents that are inside. Now, there's also a primer, like we talked about, which is a detonator, and it can be composed of three things. So lead stiphnite, barium nitrate, antimony, and there's again different types further, which is Burden, which is 1 flash hole, and Boxer, which is 2 flash hole. Okay, now let's talk about the parts a little further. So I said there's different types of gunpowders, right? So there's black powder, which is potassium nitrate 75%, charcoal 15, and sulfur 10. Then there's this is right here. Then there's smokeless powder. It's based on nitrocellulose. It has higher velocity, it's more lethal, and there's barely any smoke coming out. Then there's semi-smokeless, which is kind of in between because smokeless is expensive. So semi-smokeless is kind of like a mixture of the two, just to make it a little more cost effective. Then we have the wad, like I said before. So what the wad does is it basically separates the pellets from the powder, okay? It prevents the gas from escaping. It acts as a piston and it lubricates the bore. If the huge wad, by the way, is inside the body, that means it was a very close or a contact shot. Okay, now when it comes to a projectile and shotguns, what exactly is it composed of? So it's pellets, which are like multiple lead balls, which can be soft or hard. So you can see these are soft shots, these are hard shots, and that it could also be a slug, which is a single large projectile. It can also be nails, glass, stones, and metal pieces, and so on. So you can see that this is the case, and then this is the wad. Here as well, this is the wad. And then we have the gunpowder, and then we have the pellets, right? Okay. Now let's come to rifling. So rifling, like I said before, is spiraling of the grooves inside the barrel. Okay, it improves accuracy. Now, there's grooves and there's lands. So Grooves are like the raised parts, and lands are like the depressed parts, basically. Now, there's an advantage of rifling. Like I said, it spins the bullet and increases the accuracy, and this improves the range as well. So the person can shoot like further out. And then rifling marks are unique. So rifling marks can also be present on the bullet itself. And that kind of like helps you identify that this bullet belongs to this gun, and then you trace back the gun. Okay, so again, gunpowder already talked about. Then the components of the shotgun. So the primer, the case itself, the powder, the wad. You can see the wad is big. So if this wad is inside the body, that means it was pretty close contact. Okay. Now let's talk about the caliber. So the caliber is the diameter inside between the opposite lands. So I said the grooves, so the land is the raised and the grooves are like depressed, basically, okay? Sorry if I mixed the two before. So the distance between the opposite lands, so these lands over here or these lands over here, is the caliber of the gun. For example, 0.303 rifle. Now, the rifled firearm cartridge is different from the shotgun one we just talked about. So in a rifle, there's bullets. In shotguns, there's pellets, okay? That's the most important thing for you to like remember here. So the components of a rifled gun, is there's a cartridge case similar to the other one. There's a primer, again, similar to the other one, gunpowder, similar. And then there's a bullet, okay? Now this bullet is made out of lead with varying amounts of antimony. And that provides support and strength. So the cartridge is the whole unit, and the bullet is only what goes through, like what is the projectile part. Now the bullet itself has parts. So there's the base of the bullet, the body of the bullet, and then the nose of the bullet, okay? And there's different types of bullets, which I've added here, but the doctor said they're not very important, but I've still added it just in case. So there's round, square, pencil, and flat. Then we have projectile and shotguns. Okay, let's talk about some bullets before. So there's jacketed bullets, there's full metal bullets, which are covered completely. There's semi-jacketed, where the nose is exposed. Where is a semi-jacketed? Yeah, here. So the nose is exposed, and this causes more tissue damage. Then there's mushroom bullet, which kind of expands on impact, and that causes tissue destruction. There's dum-dum bullets, which have a hollow nose, and causes a large wound. There's an explosive bullet that contains explosive material. Then there's rubber bullets, which are used for crowd controls if there's protests and stuff. And then there's tandem piggyback bullets, which is right over here. So what happens is that the first bullet is stuck in the barrel, and then the second one pushes the first one. So they both come out at the same time, and they can both be in the same wound. I forgot to change this heading, so completely ignore it. But these are just types of bullets. Now, the case itself can be in different shapes. So there's a belted case, there is a rebated case, there's a rimless, semi-rimmed, and rimmed. Okay. More gun stuff. Yay, okay. So, rifling marks on the bullet. I told you that there's over here you can see the rifling marks, and they're mostly from the lands and grooves, and it can also be secondary to the irregularities of the barrel itself. Now, the discharge products from a gun when a projectile exits, it can be flame, gas, powder, soot, which is the black material, and the bullet itself. Now, you need to estimate the range at which the fire was shot. So it could be close range, which would usually have soot and blackening. There could be intermediate range, which would be tattooing, stippling. Or it could be distant range, which means no soot and no tattooing. Now, how does the injury take place? So basically, the bullet crushes the tissue and the tissue is displaced outwards. This produces a cavity, okay? There's a permanent cavity which is the same as the bullet itself. But there's also a temporary cavity. Now, this temporary cavity happens because of the force at which it's coming with, right? So what happens is that the temporary tissue expands around the bullet and basically makes a path. So this is the permanent cavity, and this is the temporary cavity. So temporary tissue expansion around the path of the bullet. This happens mostly in high velocity weapons and less in elastic organs. And in less elastic organs. Now, severe damage can happen in the brain, liver, and spleen. So, what are the components of projectile wounding? So, there's penetration, where the bullet enters from. There's the permanent cavity, which is the path of the bullet. There's the temporary cavity, which is the expansion. And then there can also be fragmentation. The bullet breaks off into pieces and goes into other organs. So, the injury takes place because of loss of kinetic energy. So, the energy is lost in the tissue and not total initial energy. So, the bullet, if it remains in the body, there's more energy being absorbed by the body, so there's more tissue destruction. However, if the bullet exits the body, there's less energy transferred and less injury. Again, these are the key points. You can go over them. Then we'll go on to ballistics part 2. Okay, so now coming to firearm wounds. So how can you identify if it's an entry wound or an exit wound? This is the most important thing here. So an entry wound is where the projectile enters the body, right? Now, think with me. When you were trying to put a pin into a balloon that's blown up, okay? When you're using a sharp pin, it causes the balloon to go inwards, right? Like it becomes inverted. So this is exactly the same concept. So the entry wound, it's smaller, it's circular or oval, and the margins are inverted, like you can see here. So it goes through here, and it's going inside. The tissues are going inside, okay? The skin is retracting inwards. This happens because of the skin elasticity, which resists the force of something trying to go in. The associated findings with these are abrasion collar and a grease collar. Now, abrasion collar is this thing right here, and this is a grease collar. We'll talk about it more. So now let's come to an exit wound. So an exit wound is where the bullet leaves the body, right? Exits the body. Now, think with me. If a bullet went inside from here, okay, it's going all the way through into the tissues, etc., etc., etc. Now it has to come out. It still has a lot of force. However, kinetic energy is absorbed by the body, but it's still coming out with a lot of force. When it's coming out with a lot of force, it kind of everts anything in its path, okay? This is why the wound itself is larger, it's irregular, and it's everted because it wants to come out, like right over here. This happens because there's unsupported skin that's tearing towards the outside. Okay, this is just a mnemonic just to help you guys. Okay, now coming to the track of injury. So it's basically the path that it traveled by the projectile inside the body. The range of firing depends on the distance between the muzzle and the target, so the front end and the victim. Then what's important during autopsy, it's to identify if it was rifled versus smoothbore, the nature of the projectile, the nature of the propellant, direction of firing, and the range of firing. Now, what's an abrasion collar? It's basically produced by friction and spinning bullet. It surrounds the entry wound, and it's usually 0.3 centimeters. So these are abrasion collars. And then there's a contusion collar, which is basically bruising. Now you can see here, this is straight up. However, this is coming at an angle. So this is what differentiates the direction of firing. Then we have a grease collar. Grease collar is when the bullet carries the lubricant and dirt from the barrel and deposits it around the entry wound. So the grease collar is inside, it's the inner ring, and the abrasion collar is the outside. So over here, you can see the grease collar is inside and the abrasion collar is outside. And in the center is the entry wound. Okay. This is just a table, and it shows you the effect of each component. So the projectile itself causes a wound, the entry wound, exit wound, and the abrasion contusion collar. The smoke of the gun and the soot that cause the smudging or the blackening of the skin. The gunpowder causes tattooing. The gases cause blast effect. And this is particularly important if it's like a close contact shot, which we'll talk about. Then we have flame, which is singeing, like we talked about singeing the hair in electrocution. It's kind of like a similar concept. Then metal particles can be present because the ring is metal. And then grease or dirt color because of the lubricant. Okay, now let's talk about entry wounds and exit wounds a little bit more. So, the entry wound can have flame, which causes scorching or singeing of the skin and hair. The soot causes blackening or smudging. However, it's important to remember the smudging can be wiped off. Then there's the unburnt powder that didn't get burned in the process of firing the projectile, and that causes stippling or tattooing. This is stippling. Then we have carbon monoxide. Now, carbon monoxide, we all know it causes cherry red discoloration. That's all you need to know here. If you see a cherry red discoloration on the skin, that means carbon monoxide was involved. Then there can also be metal deposition, which is a metal ring around the entry wound from the gun itself. Here you can see this is like blackening, smudging from the soot and the smoke. This can be wiped off. Okay, now let's talk about shotgun injuries because they're different from a rifle injuries because there's no bullets, right? There's pellets instead. So shotgun discharge releases the pellet, the wad, the cardboard, the powder, smoke, flame, and gases as well. So there's multiple pellets. You can see these small dots are the pellets. Those are the small balls that I talked about before. And the pellets are dispersed. Pellet dispersion increases with distance. So if it's being fired from farther away, it's more likely to disperse in different areas. So the greater the distance, the wider the pellet spread. Okay, now let's talk about exit wounds. So, like I mentioned before, they're large, they're irregular, and they're torn or everted. Okay, everted, exit everted. Okay, there's no tattooing, there's no blackening, there's no abrasion collar, grease collar, most of the times because these are things that happen in the beginning because of the components, right? Because of the soot, the powder, and so on. By the time it's gone through the whole body cavity and it's coming out, none of these things are present. However, bone fragments may act as like secondary missiles, projectiles, basically. Now, there can be multiple exit wounds, which kind of makes it confusing if there's one entry and multiple exit wounds. This happens because of bullet fragmentation, bone fragments, or it could ricochet. Ricochet, as in like it could move around the body and it breaks off and multiple parts go in different places and then they come out. And there's also cases where the exit wound may be absent, and that is if the bullet stays in the body or it exits through the same wound, or in some cases is lost in vomit, cough, or feces. Now, the importance of the exit wound helps determine the direction of firing, if it was straight through, at an angle, and so on, the posture of the victim, and the number of bullets. Okay. Now, this is just another table from the lecture itself, just to help you identify. Now, I want you to pay attention to this table right here. So, contact or close shot, there's a single large destructive wound, okay? There's a big one. Intermediate, it can have a central defect and pellets surrounding it. And distant is multiple pellets. In the case of a wad inside the body, that means it's very close range, so it just went right through. Okay, now let's talk about the range of fire. So point blank means a contact shot. The muzzle end of the gun is directly in contact with the skin, okay? So the features are, there's a muzzle imprint, because we know it's circular, so this is the imprint of the muzzle itself. There's internal blackening or charring. there's cherry red tissues and gas enter the tissues. Now, the blackening, charring is because all of the components that were outside before, the suit and so on, are now inside, okay? That's why it's causing internal blackening. The cherry red could be due to the carbon monoxide, and then the gas enters the tissue. Okay, now what is blast effect? Now, blast effect is the when the gun is fired at contact at point blank. What happens is we all know that the gun has a lot of force, okay? Now, this force is emitted in inside the body, okay? The force and the pressure builds up internally, and that's what causes the entry wound to become everted because there's so much pressure inside now that it's pushing everything towards the outside, and that's why it becomes everted. This is seen mostly over bone, over hollow organs, or the skull. So again, entry wounds are usually inverted, except if there's blast effect, okay, which is contact. Okay, then we have close shot. Close shot is when the victim is within flame range. So at this point, you see everything. You see scorching, singeing, blackening, tattooing, abrasion color, grease color, and the cherry red carbon monoxide track. The shape is dependent, but it can be circular if the shot is perpendicular. It can be oval if the shot is oblique. Now, when it's oblique, the abrasion color is wider on the side the bullet came from. So one of these like over here, as you can see. So this is a side shot. So you can see that the collar is different. It's pointed more towards one side. So, and the powder distribution is greater on the firing side. Okay, now in intermediate shot or near shots, which are outside the flame range, but within the powder range. So the powder causes the stippling effect, the tattooing, basically. So the tattooing is present, but the abrasion and grease color are absent. There's no singeing. And the blackening is also absent if the range is past 30 centimeter. Okay. Distant shot is basically beyond the powder range, so you won't see anything at all. You'll just see the wound itself. Like over here, you don't see any tattooing. You don't see any of the features. So over here, the things you'll find are a circular entry wound, inverted edges, abrasion color can be present, grease color can be present, but it's completely dependent on the situation itself. But what's absent is tattooing, blackening, scorching, singeing. Okay, this is another table. It says the exact same thing. You can go over it as like a summary. Okay, now coming to keyhole defect. Now this happens when the bullet strikes the skin at an angle. When it strikes the skin at an angle, it causes an elongated wound. So this is like an elongated wound. This is like a entry wound and an abrasion pattern. So it's the same thing. This is a keyhole defect in the skull. Okay, these are the components of a what happens after a shot. So you have the entry wound, the grease collar, abrasion collar, the tattooing, and the smoke. This is what I was talking about when I said blast effect, where there's so much pressure build up inside that it pushes, everts the edges. Okay, this is another table. We can go through it. Okay, so what do we examine in such cases? So we look for missile holes, in case a missile was used, God forbid, bloodstains, burning, singeing, blackening, tattooing. The clothing helps us estimate certain things. So it can help us estimate the range, entry or exit wound, and the location itself. Now, radiological images are very important. X-rays are very quick, and they can help you identify if where the bullet is located, if it's in fragments, the track of the bullet, if there's any fractures caused because of the bullet, if there's bullet embolism, or to just preserve forensic evidence. Now, evidence is collected via clothes, bullets, fragments, pellets, the skin around the entry, because then you send that for gunpowder analysis because you want to know what kind of gun it was as well. What firearm was used, basically. Now, autopsy examination, you do an external examination of the location of the wound, if there's tattooing, blackening, abrasion color, grease color. Internally, you look at the track of the injury, how much organ damage was caused, and shotgun injuries usually show multiple entries, but exits are uncommon because it goes like there's a one entry and then the pellets disperse. So because they're small, they don't really have enough force to come out of the body. Okay. Medical legal importance, it helps us to determine the type of firearm, the range, direction, cause of death, if it was accident, suicide, or homicide. Okay. Again, this is just a table which kind of tells you if the injury itself was an accident. That could be in the case if it was close range, if there's one wound, if the firearm is still present in the gun. If there is this is accidental. So if there's no motive and no suicide. Suicidal injury is when suicidal injury has to be at a location they can access, so it's the head or chest usually. The range is either close or contact. Number of wound, again, it's usually just one. Firearm, again, is present. The weapon is at the scene. They have a motive, and there's a suicide note. Homicidal can be in absolutely any place. The range can vary from close to distant, like it could be whatever. Direction, again, could be any. Number of wounds could be one or multiple. The firearm is usually not present at the scene. And the firearm residue is also not present on the hand because it's a homicide, someone else did this. Motive is present, revenge, robbery, or just a hate crime, and a suicide note is absent because it's a homicide. Okay, again, key points, you can go through them, and let's come to questions now. So, a temporary cavity results from stretching of the elastic tissues. Which of the following has an elastic nature and can recover from stretching? So, brain, muscles, liver, spleen. So, the answer here is muscles, because muscles can stretch. Okay, which of the following is a characteristic of a contact wound? Inverted, everted, smaller than bullet, or shaped as an wary? So I said contact wound, it would be everted. Okay. In firearms, antimony sulfide is a component of which of the following? Smokeless powder, black powder, primer, cartridge, projectile. So it's part of the primer. Okay, now coming to toxicology. Okay, this is irrelevant to be honest. I just added it just, to cover all bases. This is Matthew. He's considered the father of modern toxicology. You can read about the Marsh test if you'd like. It's a whole story. I don't think it's ever come in the exam. And it's not very important either. So what exactly is toxicology? It's the study of drugs, poisons, or any substances that are toxic and their effects are harmful on living organisms. This includes alcohol, drugs of abuse, which we'll talk about, heavy metals, and chemical poison. So poison, the word poison, it can be in a small quantity or in a big quantity. But the thing is, the dose makes the poison. So even things that are not very toxic, if the dose is large enough, it can be poisonous. So toxicology is used mainly in three forensic areas. It's to determine whether the behavior was influenced by external factors such as drug or alcohol. It's to detect the manufacture or use of illicit substances and to identify toxic substances that can cause death. Okay, so what's an intoxicant and what's a poison? So intoxicant means it requires large amounts to be fatal, such as alcohol and carbon monoxide, okay? True poison, it's fatal in very small quantity, which is cyanide. The toxicity depends on the amount that enters the body, the duration of exposure, and the route of exposure. So most of the poisons, they don't produce any gross changes, you won't be able to tell, which is why they require tissue analysis, fluid analysis, and lab testing. Now, the best sites for sampling for toxicology is the site of entry, which if it's oral, it can be the mouth. If it's IV, then it's the blood. Site of concentration, and route of elimination. So if it's oral, for example, site of entry is the mouth, concentration is stomach, and elimination is the rectum, and so on. Or urine, sorry. Okay. Toxin distribution clues. So ingested toxin can be in the stomach, where it's absorbed, intestines, liver. Inhaled toxins are in the lungs. Intramuscular are around the injection site, and intravenous in the blood. Highest concentration in the blood and low in the digestive tract. Now, what's biotransformation? So, biotransformation is basically when the body breaks chemicals down to eliminate them. And the breakdown products are then called metabolites. Now, important thing to remember is there are various metabolites that can cause false positive in certain tests. So, let's take an example. Heroin is metabolized into morphine. So, detecting morphine means that it could indicate heroin use. Sometimes we detect the metabolite rather than the original drug because it's already broken down. So, the best specimens for poison detection are blood, which is the most important because most of the time these are IV and that's the highest concentration. It shows the drug, the metabolite, and the levels at the time of death. There can also be urine. It's easy to obtain, high concentration of toxin, and this is along the elimination pathway. Then finally, stomach contents, because digestion stops at death, and it's useful in oral poisoning. Now, again, with anything, you need to identify the manner of death. So it could be natural, it could be an MI caused by the drugs, it could be accidental. Natural could be MI, accidental could be children ingesting the chemicals, like they see certain pills lying around and they think it's candy and they just take it. Misreading labels, chemical mixing. It could be suicide where there's a drug overdose, or homicide if there's deliberate poisoning. So these are all like the toxic material that we'll kind of go over and talk about. So we have alcohol, cyanide, strychnine, ethynyl glycol, arsenic, mercury, lead, insulin, acids, and alcohol. Okay, now let's start with alcohol first and foremost. So alcohol is most commonly abused. It mainly acts on the central nervous system, and that causes the feel of intoxication, basically. So blood alcohol is expressed as grams of alcohol per 100 milliliters of blood. So alcohol is taken orally, right? So the absorption occurs through the stomach and the small intestine. However, the factors that affect it are the amount that's consumed, the concentration of alcohol, which I think tequila as a shot contains more, right? So it's more concentrated. The time of drinking, the weight of the body, and the food in the stomach. So empty stomach affects more. Then we have presumptive tests, so tests that you can do to detect alcohol intake. So there's a breathalyzer, which estimates blood alcohol concentration. Then there are field sobriety tests. So in movies, we see that there's someone driving, and then they get pulled over by the police, and then the police thinks that the driver is under the influence. So they make them do a sobriety test. They check for nystagmus. They check for any pupillary changes. They ask them to walk and turn. They ask them to stand on one leg and then do the finger to nose test. These are basically hand-eye coordination, which if you're intoxicated, it becomes hard to perform. And this is used for rapid screening. Now, the amount or the level of alcohol in your body causes certain things. So above 30, you cannot do complex skills such as driving. 30 to 50, it deteriorates your driving skill. 50 to 100, it's loss of inhibition, laughter, sensory disturbance. And you can just read this further on, but this is important because there are questions on it. So how is alcohol eliminated? It's eliminated via oxidation and excretion. So oxidation takes place in the liver, and then so on. Okay, now let's talk about other poisons. So cyanide is extremely lethal, which means even a small amount can cause death. And this causes bright cherry red blood. Strychnine is used in rat poison. It causes severe painful spasms, and it also causes heat production. Then there's ethynyl ethylene glycol, which is antifreeze, which is also called antifreeze poisoning, and it's sometimes ingested by alcoholics. Then we have certain heavy metals that can also be poisonous. So there's arsenic. Arsenic poisoning, as you can see here, it can cause hyperkeratosis. It can cause pigment changes. It increases the cancer risks such as lung, bladder, and kidney and liver. And it also causes circulatory problems and nerve damage. Then we have mercury. Mercury is present in seafood, and excess amount of mercury can be harmful, which is why pregnant women are told not to eat sushi and so on. Then we have lead. Lead is neurotoxic and it used to be in gasoline, so leaded petrol used to be a thing, but it's been ages since it's not anymore. Okay, then we have insulin poisoning. Insulin is therapeutic for diabetics. However, if they overdose, it can be fatal. This can be used in Munchausen by proxy, which we'll talk about, and homicide. Then these are some corrosive poisons that cause burning of the mouth, esophagus, and stomach, which are called caustic injuries. Now, how do you test for these? You test for these through gas chromatography, which is GC. It's most widely used. There's also mass spectrometry, which identifies the substances by the mass, by the molecular mass. Often they're combined, so it's called GCMS, which is the gold standard. It basically breaks the substance down and then identifies the mass or weight of the substance. Okay, again, these are key points, and this is the second part of the toxicology lecture. Okay, so there are substances that can affect the brain, causing changes in mood, perception, behavior, and function. So some terms that you need to know are addiction. So addiction is when there's repeated compulsory use, like the person wants to do it over and over and over again. Then there's habituation, which is repeated non-compulsory use. At one point, the person is just used to it so much, and that now they just do it as like second nature. Then there's dependence, which can be dependence is when there's physical or psychological adaptation. You undergo certain things which make you seem like you're dependent on the drug. And then there's drug abuse. If it's outside medical, social, and legal use, it's called drug abuse. Then let's come to tolerance. So tolerance means you can tolerate a certain drug, right? But with repeated use, the tolerance keeps like getting more. So increasing the dose causes the same effect as it used to before with a smaller dose. Okay. Cross tolerance means that tolerance to one drug causes tolerance to another drug. And then there's different types of dependence as well. So there's psychic, where there is craving and behavioral changes, and there's physical, where there's withdrawal symptoms. And withdrawal symptoms can be after stopping or reducing a drug even. Okay, so we already talked about what these stand for. Let's talk a little bit about substance abuse. So abnormal use causing social impairment, occupational impairment, and physical harm. This is substance abuse. Now, when there's substance dependent, it basically means substance abuse plus tolerance, which means more of the drug is causing the same effect than that was achieved with a smaller amount before. Withdrawal, and physical and psychic dependence. Now, these are the drugs and what kind of dependence they cause. So, opioids cause physical, amphetamines cause psychic, cannabis cause psychic, cocaine, physical, benzos, physical, barbs, physical, and hallucinogens such as like magic mushrooms, shrooms cause psychic. Okay, now let's talk about amphetamines. So the mechanism here is that they're CNS stimulants, okay? They block the reuptake of dopamine, serotonin, and norepinephrine. That causes the feel-good vibe. The medical uses here are ADHD, narcolepsy, and appetite suppression. So the effect of this is euphoria, the person is alert, talkative. However, there's dilated pupils, there's tachycardia, there's hypertension, insomnia, and loss of appetite. Severe toxicity can cause agitation, hallucinations, paranoia. The person thinks that there's people out to get him, hyperthermia, arrhythmias, and convulsions, which are seizures, as we all know. There's different types of amphetamines. So there's prescription and then there's recreational. So recreation, there's methamphetamine or meth. There's MDMA called ecstasy or E. And then there's Captagon, which is phenethylene, which used to be very popular, but now is discontinued and not made anymore because of its toxic effects. Now, the problem here with over-the-counter is that the over-the-counter drugs can cause false positive because there's cross-reactivity of the metabolites. And this can be pseudoephedrine or ephedrine. How is screening done? Immunoassay is used in the beginning initially, and confirmatory is with GCMS, like we talked about before. Now, another thing with amphetamines is that it can cause subarachnoid hemorrhage, like you can see here, because of hypertension and so on. Okay, now let's talk about cannabis. Cannabis is also weed. So this is a cannabis plant, Cannabis sativa. It can produce marijuana, hashish, or hash oil. So the active ingredient is THC. Its mechanism is it acts on CB1 receptors. THC is lipophilic, which means it's stored in fat. Low doses of weed can cause relaxation, euphoria, increased appetite, and sleepiness. So this is marijuana and this is hashish. However, higher dose causes alert perception, poor coordination, memory impairment, and this distorted sense of time. Toxic effects include panic, hallucinations, paranoia. Again, you feel like the person feels like someone is out to get them. Then psychological effects are red eyes, tachycardia, increased appetite. This is how weed is usually consumed. It's rolled up and then it's smoked. Then there's chronic use, which can cause lung disease and amotivational syndrome. Detection, you can detect it if there's casual use 2 to 3 days, and heavy use, weed can be detected in the body from weeks to 45 days. The medical uses are it can be used in glaucoma, in nausea due to cancer or chemotherapy. I think it's prescribed as medical marijuana in the States for cancer patients. And then there's AIDS wasting syndrome. Okay, now coming to opioids. So there's different types of opioids. So there's morphine, heroin, codeine, methadone, fentanyl, and tramadol. Opioids act on different receptors. So if it acts on the mu receptor, it causes euphoria, like a feel-good vibe, respiratory depression, and dependence. For kappa, if it's the kappa receptor, it causes meiosis and CNS depression. And for delta, it causes analgesia, which is why it's given for pain sometimes. The antidote for opioid overdose is naloxone. And how do you know if there's opioid poisoning? There's a classic triad, which is coma, respiratory depression, and pinpoint pupils. There are other features such as cyanosis, hypothermia, and vomiting. And the terminal or fatal features are it can cause respiratory failure and circulatory collapse. Now, this is the opium poppy. It's the plant that the opium comes out of. This is how you prepare it, and then it's either snorted or injected. Now, the withdrawal symptoms are lacrimation, which means like tearing up, rhinorrhea, sweating, muscle aches, diarrhea, and dilated pupils. The heroin tox screen can't differentiate between heroin, codeine, morphine, and morphine because they have the same metabolites. Now, again, these are either smoked, injected, or snorted. The hallmark is 6-MAM detection in urine. And the confirmatory test, again, it's with GCMS, like I mentioned before. They're too long to say over and over again, which is why I'm using the short form. Okay, now let's go on to cocaine or coke. The source is coca plant. The plant looks good. Like the plant is a very pretty plant with a horrible production of cocaine, okay? The forms can be either cocaine powder or crack cocaine. The mechanism is it blocks the reuptake of dopamine, serotonin, and norepinephrine, similar to what we talked about before. Causes euphoria, hyperalertness, anxiety, hallucination, dilated pupil, and tachycardia. The finding that's characteristic for cocaine is that it feels like there's worms under the person's skin, and this lasts for about 2 hours. Now, cocaine can either be snorted or injected, or if it's crack cocaine, I think this guy is like, you know how you smoke a cigarette, so he's smoking the cocaine, and when the crack form is used, it has this bubbling, like a cracking noise to it. The complications are vasoconstriction. Because of vasoconstriction, there can be MI, stroke, sudden death. If it's snorted, it can cause septal nasal necrosis, like you can see here. It can also cause weight loss, pulmonary damage. As you can see here, it can also cause like stroke and necrosis. Now let's talk about other miscellaneous drugs. So there's drug-assisted rape, which is uses of substance to impair resistance or memory, and common drugs are alcohol if taken in a high proportion, or refinol, which is roofie, which is a forget pill. It's similar to Valium, it's 10 times stronger, and it causes amnesia, sedation, and muscle relaxation. And this is more details on roofie, but they won't ask you about it. Okay, now let's go to barbs, benzos, and more. So barbs are used for sedative purposes, hypnotics, and anti-epileptics because they enhance GABA activity. However, it causes drowsiness, slurred speech, and nystagmus. Overdose can cause respiratory depression, coma, or death. And then now, forget this. Now let's go on to hallucinogens. So hallucinogens can be in different forms, so it could be LSD, psilocybin, which is magic mushrooms, mescaline, or MDMA, and ecstasy. So the effects are it causes hallucination, distorted perception, anxiety, and dilated pupils. The dependence is mainly psychological. So what does LSD do? It causes visual hallucinations and altered reality. It increases BP, pulse, and temperature. And with LSD, you get flashbacks weeks to months later. Now, for benzodiazepines, they're more safer. They have less risk for respiratory depression. The overdose risk is also less, and it has an antidote. It's called flumazenol. Okay, these are the key points. Questions. Which of the following is a rat poison that causes pain when ingested? So, again, this is A, strychnine, however you pronounce that. Which of the following drugs cause psychic dependence? So, cannabis. So, B. And then, serum level of ethanol greater than 400 causes what? Causes loss of protective reflexes, which is A. Okay. Now coming to the lecture of sexual offenses. So, sexual assault is basically any unwanted sexual activity. It could be touching, fondling, or penetration. It's done without consent. Consent is key. And it's an act of violence, and it can be directed towards males or females. Now, consent requires certain aspects to be fulfilled. So, valid consent requires adult age, mental competence, no fear, no threats, no fraud, fully conscious, and there's no intoxication or anesthesia that took place. Consent can also be withdrawn at any time, and any consent under drugs or alcohol is invalid. Any consent given by a minor is also invalid. Okay, there's different types of sexual offenses. So there's natural, unnatural, sexual perversions, or other sex-linked offenses. First, we have rape, which is unlawful sexual intercourse. It's against the will, without consent, it's by force. It can include an underage victim, a intoxicated victim, threatened victim, mentally unsound victim. So what are the components or what constitutes as rape? So slightest penetration is sufficient, ejaculation not necessary, rupture of the hymen not necessary, semen not necessary, and absence of injuries does not exclude rape. So anyone who comes to the hospital or to the physician and says that they've undergone this, you need to treat them with utmost respect. So there's different types. So custodial rape is when there's an authority figure doing this. Gang rape is two or more. Statutory is when it's with a minor. The key point is consent under drugs or intoxication is invalid. So there's a will and a consent. So it can be against will, active refusal, usually conscious, always without consent. So will is always without consent. And then consent. So without consent, there's no valid permission. They may be unconscious and intoxicated, so they don't know what's going on, and it's not always against your will. Okay. So as a doctor, how do you examine the patient? So the doctor must treat the patient, the victim, respectfully, maintain privacy, be empathetic, don't rush things, document findings very clearly, and collect DNA evidence. A victim is always treated as a possible rape victim. So, what are your objectives? So, your objectives is to always get a history, collect evidence, treat injuries, prevent STDs and pregnancy, and provide psychiatric and mental support. So, what you find in this examination could be torn skin, missing buttons, deranged hair, nail abrasions, bruises on anywhere on the body, bite marks, or subconjunctival hemorrhage as a sign of force. Then there can be genital injuries such as abrasions, bruises, tears, bleeding, edema. The tears acronym stands for tears, ecchymosis, abrasions, redness, and swelling. As a forensic physician or as a doctor, your responsibility is to document the time, date, and place, the circumstances of assault, the mental status and intoxication level, the last consensual intercourse because it might interfere with the current investigation, because of the duration of sperm, like living sperm, and then menstrual and obstetric history, and delay in reporting. Now, written informed consent is required. The police stay outside the room. It's preferably the examination is done with by a female. If that's not possible, a female attendant has to be present. The examination should not be detailed because it's very vital to write everything down, injuries, and collect the evidence because the injuries fade very quickly and sperm detection decreases with time. Here is an image of all the signs of injuries that you can find. Okay, so what kind of evidence do you collect? I remember this came as a SAQ for us. So clothes, blood, hair, nail scrapings, vaginal, oral, anal swabs, seminal stains, saliva, fibers, and debris. It's important that the victim undresses over clean brown paper so that you can identify any evidence that was to fall on the floor. The swabs are taken from the vulva, lower vagina, upper vagina, cervix, oral cavity, and the anus. Presence of sperm means intercourse, but that does not prove rape. Signs of struggles could be broken nails, skin fragments, hair under nails, defense injuries. Absence of struggle does not mean that consent was provided. The chain of custody, as I mentioned before, it's very important to individually pack so that there's no altercation done with the evidence. It should be labeled, date, sealed. Every transfer must include all of these components such as name, date, time, and signature. Now, let's talk about child sexual abuse. So when you examine a child as a doctor, it's very important to not to restrain the child because children move a lot, which is why examinations like this need to be done under anesthesia. And in cases like children sexual abuse, there's minimal resistance injuries and the hymen may remain intact because it's higher up. However, you can find bruises, injuries, and more severe injuries in younger children. Now, one second. Okay. Time of assault is correlated with the type of sperm present. So motile sperm is 6 to 12 hours, non-motile is 24 to 48, and rare persistence is up to 72 hours. This helps in dating the injuries and to prevent the development of STDs. Okay, so what do you do post-collection? So you follow-up care includes injury treatment, tetanus prophylaxis, STD prevention, pregnancy prevention, and psychiatric mental support. So there's a thing that's called rape trauma syndrome. It has two phases: disorganization, which has anxiety, depression, guilt, and emotional instability because they've gone through a lot. Then there's another phase called reorganization that has nightmares, fears, phobias, avoidance, and sleep problems because of the trauma that they've faced. Now, coming to false allegations. So, some suspicious features are inconsistent history. If two people give you different history, two people involved in the crime give you different history, it makes you suspicious. If the injury timing does not match with what you were seeing while you were examining, if there's self-inflicted injuries, and if there's no lab findings. False allegations mostly are uncommon. Lack of evidence does not mean it's a false allegation, so you have to tread very carefully with these cases. Okay, so how do you examine the accused? So you look for scratch marks, bite marks, genital injuries, and the DNA of the victim. You collect specimens from clothes, hair, blood, nail debris, saliva. Make sure to avoid contamination throughout this whole process. Okay, some other sexual offenses include incest between close relatives, adultery, intercourse outside marriage. Some other unnatural sexual offenses include sodomy, which is anal intercourse, lesbianism, female homosexuality, bestiality, sexual intercourse with animals, buccal coitus is oral sexual intercourse. Bestiality, you can find animal hair, feces, penile injuries, human sperm in animal tract, and so on. Sadism is gratification by inflicting pain. Masochism is gratification from receiving pain. Transvestic fetishism is arousal from cross-dressing, like a man dressing as a woman dressing as a man, and so on. Necrophilia is sexual attraction to corpses or dead females. Lust murder is when a homicide is committed where he stabs, pierces, slashes, or mutilates the organs of the victim's body. Okay, these are the key points. You can go over them. Now coming to questions. Which of the following is a correct duty of a doctor in case of an alleged victim of rape? Any female of any age, including any child who claims to be a victim of sexual abuse, should always be treated as a possible rape victim. That's the answer. A girl was raped by a warden in jail. What kind of rape is that? Custodial rape, because it's in a position of authority. A 26-year-old rape victim was examined and specimens were collected from her body. When the sample side was examined, motile sperms were seen in the wet smear. How long ago did the rape take place? 6 to 12 hours. You can go back to the table, make sure you learn it by heart. Okay, now coming on to neglect and starvation, and then we have our final lecture, child abuse. So neglect is the most important form of child abuse. When you come to your PEDS rotation, you will be told that neglect is the most common form of child abuse as well. It can be intentional or unintentional. So it's basically when the caregiver fails to provide adequate care for a dependent person. This results in harm, illness, malnutrition, death. One second. That should not be there. Okay. So harm, illness, malnutrition, death. So the victims can be children, elderly, or disabled people. Any of the vulnerable population can be neglected. So there's types. So there's physical, where there's poor feeding, delay or refusal of healthcare, such as vaccinations or checkups, poor supervision, and abandonment. Educational, it can be truancy or failure to enroll in school, or not taking care of their educational needs as a whole. There can also be emotional neglect, which is lack of attention, which causes exposure to drug, alcohol abuse, or delay of psychological care. Like they should be provided with mental health support if they need it. Then the red flags are of neglect that show you that signs of neglect are present in this child are poor hygiene, developmental delay, and repeated untreated illnesses. Okay. Now coming to starvation. So what is starvation? It's when there's deficiency of food and nutrients, causing wasting and organ failure. So this can be due to inability to eat, voluntary fasting or hunger strikes, mental illness, accidents or disasters, and deliberate withholding of food. So with everything, there's an acute and chronic phase. So acute starvation is when there's sudden total absence of food and water, and chronic starvation is when there's gradual, prolonged malnutrition. Both of these cause weight loss, muscle wasting, and weak immunity. What's the pathophysiology? Okay, this is more biochem. I don't think it's very important for the exam, but it's important to like establish a concept in your mind. So the glycogen is depleted within 24 hours, after which the body starts breaking down fat and muscle. Now, lipolysis produces fatty acids and ketone bodies. Ketosis and ketonuria can occur, but however, the weight of the brain is relatively preserved. So what happens is that because of any disease, malnutrition, or any of the reasons, there's a reduced intake of food. This causes loss of body weight. Now, loss of body weight causes increased susceptibility to infections, further deterioration, or it can lead to death, physical and psychological deterioration, and basically it causes a cachectic habitus, which is you can see right here. The ribs are, you can see the ribs, they're very, very prominent. There's barely any fat or like muscle tissue that you can see. You can see the iliac crest, the iliac bones, the pubic bones very well. And the child is very, very thin. Okay, so acute versus chronic. So acute starvation, early on, what happens is that it, your stomach starts hurting because the person's stomach starts hurting because there's so much hunger. Then there's intense thirst and epigastric pain. Later on, there's fatigue, irritability, weight loss, and mental lethargy. And then moving on even further, there can be hallucinations, weakness, and mental impairment. The findings that you see here are emaciation, prominent ribs or bones, muscle wasting, dry, wrinkled skin, loss of skin elasticity, sunken eyes, hypothermia, hypertension, weak pulse, and so on. Death usually takes place after 40 to 50% of body weight is lost. Now, what about chronic starvation? It can cause anemia, hypoproteinemia, edema, poor wound healing, and recurrent infections. In females, it can cause irregular menstruation or complete loss of menstruation. Late, again, similar to the acute, it can cause hallucinations and convulsions, which are seizures. Now, what's the fatal period? So, fatal period is when there's no food and no water for 14 to 21 days. That will kill a person. If there's no food only, a person can last 36 weeks, sometimes even 8 to 12 weeks. Okay. Now, what will you find on at the postmortem? So, autopsy finding will show severe emaciation, loss of all subcutaneous fat, and prominent bones, so skin and bones appearance. Internally, you'll see that the organs start to atrophy. The heart, liver, kidneys, and spleen atrophy. The GI tract, normally there's fat all over here, but you can see that there's no fat, and you can directly see the ribs and the intestines. The intestines are hyperemic, which means they're more red, and the bowel wall is also thin. And there's also dry stools. The gallbladder usually gets distended with bile. The immediate causes of death are dehydration, hypoglycemic coma, organ failure, arrhythmia, infection, and hypothermia. Now, in infants, it's likely to find complete thymic atrophy. This is pathognomonic for starvation. Other things you can see are liver, centrilobar necrosis, renal atrophy, pseudodysentery, and so on. Now, there's different manners of starvation. So it can be suicidal, where a person does this because of their own willingness. So it could be a hunger strike, or it could be psychiatric illness. It could be homicide, such as child abuse, elder neglect, or deliberate food deprivation, withholding of food. It could be accidental after famine, after a shipwreck, the ship is deserted, and so on. It depends on the scene, the history, and you exclude other causes. Legally, this is important because you need to diagnose malnutrition, then investigate if there is neglect or abuse taking place, if there's any other causes of death, and you review the medical records and you take photographs for documentation. Now, there's two types of protein energy malnutrition. There's marasmus and kwashiorkor. Now, for marasmus, it is due to calorie deficiency. It has severe wasting, fat stores are depleted, and muscle wasting is severe, and abdomen is scaphoid, which means it's like internally, it's like going inside. Kwashiorkor is when there's protein deficiency. The appearance is edematous. The fat stores are relatively preserved because it's protein. Muscle wasting is moderate, and the abdomen is distended. So you would see a very cachexic child, but the abdomen is distended. That is kwashiorkor. Okay. Key points you can go over it, and then questions. In acute starvation, when is the sensation of hunger maximum? 36 to 48 hours, 12 to 24 hours, 1 to 3 days, 24 to 36 hours, and 3 months. Okay, now I want you to think of a scenario. So if a person has a very busy day and they don't eat, in the first 24 hours, in the first 6 to 12 hours, they start feeling hungry. This is just the start. It kind of then builds up, builds up, builds up, and the highest peak is 36 to 48 hours, after which the sensation of hunger kind of fades away. So the answer here would be 36 to 48 hours. Okay, which of these is least likely to atrophy in starvation? So the answer is brain, because we said it's mostly preserved. Which of the following defines deprivation of one of the basic needs of a child, such as adequate food, clothing, shelter, medical care, or supervision? So the answer here is neglect. The second option was clearly added by me. I'm not a very good question maker. Okay, what does the brain utilize in starvation? So this question caused a lot of controversy in our batch because people were like, it's acetone or acetoacetate, like both of the answers are right. The most right thing in chronic starvation is acetoacetate. Okay. Now coming to child abuse, which is our last lecture. So child abuse can be physical, emotional, sexual, neglect, or exploitation. It results in actual or potential harm to the health of the child, the survival, development, and dignity. Any act or failure to act, which means neglect, that harms a child physically or emotionally is also called battered baby syndrome or non-accidental injury. Now, what are the red flags of child abuse? If you see repeated injuries or injuries at different healing, like multiple injuries, injuries at different healing stages, or history that's inconsistent with the injury, it's likely to be child abuse. Over here, you can see a hand mark on the skin. This is child abuse. Over here as well, you can see that there's multiple bruises, which is more likely to be child abuse. Okay, now let's talk about types of child abuse. So we said there's physical, which is non-accidental injury causing bruises, lacerations, burns, or fractures. So you can see here, this slap would cause a hand imprint on the face of the child. If you were to use, if the person was to use an object and you were to see on physical examination that there's an imprint of an object, that would also be child abuse. So it is your responsibility as either a forensic medicine doctor, aka a forensic physician, or a pediatrician to be able to pick up these injuries and be able to then report them to the right chain of command. Okay? Because you are who is responsible, who as a pediatrician, of the child. Okay. Then there's sexual abuse, which is violation of the child's body, mind, and dignity. Then there's neglect, which is failure to provide food, shelter, clothing, medical care, and supervision. So, drug or alcohol abusing caregivers commonly neglect their children because they're so busy within themselves that they don't realize that their child is dependent on them, basically. Now, these are common sites for bruises in children, which can be knees and shins and elbows. Why? Because children run around and children fall, and this is very, very common. This is normal behavior of a child. However, it starts becoming questionable when it's on their face, at the back of their head, on their neck, on their spine, because even if a child was to fall, these are not places where he would directly get injured. Calves, back of thighs, in between the thighs, and so on. So infants and young children are mostly vulnerable. So again, as a Physician, it is your responsibility to be able to pick these things up because a child is least likely to tell you what is going on. 84.5% of fatally abused children die before the age of 6, and most deaths occur in the first 2 years. So, what is fatal abuse? So, usually, abuse is manual via hitting, beating, shaking, throwing, dropping, burning, suffocation. Less commonly, it's with a weapon or a blunt force trauma. The major causes of death in children is head injury because of formation of a subdural hemorrhage, subarachnoid hemorrhage, or cerebral edema. So here you can see formation of subdural hemorrhage. So just underneath the dura, you can see a hematoma forming. And then cerebral edema, all of these things can result in cardiorespiratory failure. Other causes of fatal abuse include liver spleen locks, hemorrhage, sepsis, bowel perf, and so on. Suspicious injuries, as I said before, are usually on the face, chest, back, buttocks, thighs, genitalia, and back of legs. I already talked about the normal childhood injuries, so I won't reiterate on those. You can read them through. These are very important to go through as well. Oh, oops. Okay, so pediatrician duties. It's important because 60% recurrence rate of child abuse is present. There's 10% mortality rate. So you must identify the abuse early. However, false accusations must be avoided. You can't, as a physician, go and accuse anyone because without going through their case properly. Because if you see multiple bruises and the patient has a prior condition, like a coagulation disorder and so on, you are going to get in trouble, and it's going to be a very awkward situation. Okay, now coming to surface bruising. This is the most common injury and abuse. So you find multiple bruises in different colors and ages. You can find pattern bruises or object-shaped bruises. This can be finger pad when they're pressing on the child by force. They leave imprints of their fingers. It can be small circular bruises on the neck, chest, or abdomen. Like as you can see right here from a cigarette, like cigarette butt. It could be slap punch bruises, handprints like we saw before. And then there's also deep bruising where external bruises may be absent. So at autopsy, what's done is long incisions are made in the back, buttocks, and extremities. It's basically to detect deep soft tissue hemorrhages. These are the bruises aging features. I've talked about this in the pre-med crash course in a lot of detail, so I'm not gonna go over it again here. Okay. Now coming to burns and bites. So burns in child abuse is caused by hot liquids, hot objects, or cigarettes, like we talked about this being via a cigarette butt. So thermal injury has clues. So there's forced immersion burns, which has sharp water lines and clear demarcation lines. So you can see like a clear line where the child was immersed in hot liquid or hot water. Over here as well, you can see a very clear water line. Then there's also bite marks, which can cause, like over here, it's mostly on the ear. It can cause abrasion, bruising. There can be teeth patterns, and there can be petechia. So it's important to swab this area, early for salivary DNA. Okay. Then there can also be skeletal damage based on the force. So it's mostly made radiologically via X-ray. The important things that you can find are multiple fractures. Fractures are at different stages of healing. Rib fractures, spiral fractures, and in this scenario, you need to do whole body skeletal survey. Now, rib fractures are highly suspicious in infants because the amount of force you need to break a rib is like ginormous. It's a huge amount. This is usually in infants. Obviously, they're very fragile creatures. This can be caused by chest compression during shaking, but this has to be vigorous shaking. Mostly, this is posterior rib fractures. Then other fractures that are highly suggestive of abuse are rib fractures, metaphyseal fractures, epiphyseal fractures, and multiple fractures and different stages of healing. They're very rare to take place in accidental trauma. So this is the healing of fractures. So in 7 to 14 days, new cartilage and bone starts coming through. And then bony union takes place at 3 to 6 weeks. So you can see that it's still like it's like out, like it's like an outpouching kind of phase. Here you can see these are bleeding ribs, and these are healed fractures. Okay, now let's talk about skull fractures and shaken baby syndrome. Now, it's often associated with subdural hemorrhage and brain injury. Abusive features of fractures are if they're multiple, if they're wide, if they're depressed, and if they're growing fractures. Accidental are linear, single, and parietal. Now, why are infant brains so vulnerable? It's because infants have a very disproportionate head. Their heads are very large for their bodies. They have a weak neck muscle, so that's why they have head lag in the beginning. They have thin skulls and they have high brain water contact. This makes them more susceptible to shearing injuries and whiplash injury, like we talked about in road traffic accidents, and then brain hemorrhage. Now, coupled with weak neck muscles and head lag, which it takes place until 4 months of age, there's also flat facets, as you can see here. In adults, they're more curved. This means that the large, poorly supported head of the baby is susceptible to shaking and impact. And this is what increases the risk of brain and spinal cord injury. So, shaken baby syndrome is caused by violent shaking, like vigorous, violent shaking. It results in subdural hemorrhage, retinal hemorrhage, and brain injury. Some other findings you can find are rib fractures because of compression of the chest of the baby, thoracic contusions, and metaphyseal fractures. Now, what's the difference between a subdural versus subarachnoid hemorrhage? So, a subdural hemorrhage is, it's a thin film and it washes off. And it happens because of torn bridging veins. This is a subdural hemorrhage. A subarachnoid hemorrhage cannot be washed off. It's blood within the surface of the brain. Here you can see when the skin is exposed, like when the scalp is exposed, you can see multiple bruises. This is the difference between subdural versus subarachnoid. So subdural is a crescent-shaped bleed. It does cross the sutures. It can cause retinal hemorrhages, and it's strongly suspicious for abuse. And it's because of torn bridging veins, and it's between the dura and the arachnoid matter. Subarachnoid is between the arachnoid matter and the pia matter. It's blood in the sulci or cisterna. It does not cross the sutures. It's less specific for abuse. In infants, subdural hemorrhage and retinal hemorrhage is strongly suggestive of abusive head trauma, which is shaken baby syndrome. Okay, now other random information that they put in the lecture. So there's diffuse axonal injury, which is caused by shaking forces. It may lead to neurological injury, brain swelling, hemorrhage. There's cervical spinal cord injury, which can occur without fracture. It's called spinal cord injury without radiologic abnormality. It's because of the elastic ligaments and the weak neck muscles that we talked about that infants have, and incomplete ossification, because ossification takes place later on. Eye injuries, as I said, retinal hemorrhage is also linked to shaken baby syndrome. There can be vitreous hemorrhages, lens dislocation, retinal detachment. Ear injuries, if there is bruised pinna, lacerations from slapping or pulling ears. There can also be mouth and lip injuries. This is mostly because of forceful feeding, or or the parent is trying to silence the child. So what do you look for? You look for frenulum tears. Frenulum is when you can check yourself. So if you expose your bottom lip and you pull it down, you see a line connecting the two. That is what a frenulum is. So frenulum tears, lip laceration, gum injury, and dislodged teeth. And then abdominal injuries are harder to detect externally, but internally it can be liver lac, spleen lac, bowel injury, pancreatic injury. In these cases, that is usually due to peritonitis, sepsis, or hemorrhagic shock. So, the characteristic of battered infant fractures are multiple fractures, complex configuration, which is basically depressed, wide, and growing fractures. The latter meaning widening of the fracture line even after the fracture took place. Accidental fractures are narrow, linear, and single, and usually in the parietal area. Okay, now let's talk about extremity fractures. So it can be tibial metaphyseal fractures, distal femur fractures, or proximal humerus fractures. Then there's also something called subperiosteal newborn formation. It's mostly in infants 1 to 4 months, it's normal. So this is what it looks like. However, if it's more than 2 millimeters thick and outside the normal range after this time period has passed, it is like pathognomonic for child abuse and appears radiologically after 10 to 14 days. Osteogenic Osteogenesis imperfecta is a genetic disorder. It's caused by fragile bones and multiple fractures, so it's important for you as a physician to differentiate this from abuse. This is a problem with type 1 collagen. There's also Menkes syndrome, which is kinky hair syndrome. There's copper deficiency, abnormal metaphysis, Vermean skull bones, and mental retardation. Now, what's Munchausen by proxy, which I mentioned before as well. So here, the caregiver deliberately harms the child to have a personal gain, basically to achieve sympathy and attention from someone else. And usually this is done by the mother. Then there's impulse or angry homicide. The child may be thrown, slammed, or hit violently, and this can cause fatal head trauma. Then there is gentle homicide, smothering, which is the second most common infant homicide. It's done by the caregiver by covering the nose and mouth and pillow over the face, so it does not cause any obvious trauma, and death can occur in 70 to 90 seconds. So the forensic importance is you need to identify if the injury is accidental, homicidal, neglect, or natural. You need to take full history, do the investigation of the scene, autopsy, and documentation. That's it. Now, last slide for questions. In cases of child abuse, where do posterior rib fractures occur? So they occur at the costotransverse process articulation with the vertebra. Okay. New cartilage and bone formed after a fracture can be seen on microscopic examination within 7 to 14 days, like we mentioned here. Okay. During the autopsy for child abuse case, where a child passed away, a fracture of the skull was noted, with the outer table broken while the inner table was damaged. Hemorrhage was found in the right hemisphere between the meninges, which washed off easily with water. What is your diagnosis? So washed off easily with water, and they're telling you the location, so it's subdural hemorrhage. And that is it. So forensic medicine is finally over, both for you and for me. Alhamdulillah. Congratulations to all of you guys. You've successfully finished the last parallel of third year. And past this, everything does get easy. So on to your clinical years. Good luck, Eid Mubarak, and I really hope that you enjoyed and learned from these PAL sessions that I've had the opportunity to give this year. And thank you so much, everyone. That's all.